Hi, everyone. Good morning. Welcome to those who just joined us. We'll get started in just a moment. Hello, everyone. Good morning. Right. Let me just make sure sound is good. Good morning. All right, everyone. Let's go ahead and get started. So good morning. Welcome in. It's so great to see everyone starting to join us. I'm going to put some info in the chat for everybody. If you can please type your name and your county into the chat, that would be wonderful. This allows it to make sure that you are marked present for attendance today. And then while we wait for others to join, please feel free to take a moment to stretch or do a breathing exercise or whatever might be helpful to you so that we can be present and prepared for this morning's workshop. All right, and welcome to those who are just joining us. It's wonderful to see everyone this morning. Let's go ahead and get started. All right, so welcome to the APS Leaders Institute workshop, including older adults in county behavioral health planning. My name is Emily Sulpizio. My pronouns are she, her, and I'm a training operations manager at the Academy for Professional Excellence, a part of the Adult Protective Services Workforce Innovations Program, also known as APSWI or APSWI, and I will be moderating this workshop along with our wonderful speakers today. First, I want to share that we have closed captioning available for today's workshop. If you'd like to turn it on, navigate to the bottom of your Zoom panel and select the captions option. Next, we sent you all the participant manual to utilize during this workshop, but in case you don't have it on hand, we will be posting it in the chat in just a few moments, so feel free to check out the chat if you're in need of the participant manual. And to start things off, I would like to tell you a little bit about the Academy and APSWI. The Academy for Professional Excellence is a project of the San Diego State School of Social Work. Our mission is to provide exceptional workforce development and learning experiences for the transformation of individuals, organizations, and communities. APSWI is a program of the Academy that provides innovative workforce development to APS professionals and their partners. From all of us at APSWI, we just want to say we are so grateful that you are here today. You play a vital part in the Academy's mission to revolutionize the way people work to ensure the world is a healthier place. And now, before we dive into the workshop, I'd like to take a moment with you to share something of purpose and of great value that inspires the Academy's core values and what we represent. Just one moment, I'm going to put some information in the chat for everybody. All right, I'm going to share with you all a land acknowledgement. The purpose of a land acknowledgement is to recognize the relationship of Indigenous peoples to the land. I am coming here from the land of the Kumeyaay people, and I'm going to just posted a link in the chat if you'd like to see which native land you are on. This acknowledgement of the land is multifaceted in its meaning. It shows respect to the people of the land itself, and to their relationship to one another. They are statements that recognize the disposition from the land, the harm brought by colonial practices, beliefs, and policies. They validate and recognize the continued presence of Indigenous peoples everywhere. And lastly, when offered in earnest and with sincerity, they are the first steps in reconciliation and healing. For millennia, over 100 tribal nations have been a part of this land. This land has nourished, healed, protected, and embraced them for many generations in a relationship of balance and harmony. As members of the Academy community, we acknowledge this legacy. We promote this balance and harmony. We find inspiration from the land of the original inhabitants of California. So while developing a land acknowledgement statement is an important step towards reconciliation and healing, the statement alone is not enough. It's important to also identify concrete steps and actions that can be taken. So these actions can involve putting in time and effort to research and learn more about the Indigenous communities of the lands you are on, perhaps returning artifacts and lands to their appropriate tribal communities, working to protect and preserve the land, and much more. You can use the same link that I posted in the chat to our website, which lists many ways that you can take action if you're interested in learning more. Thank you so much for participating in this moment of recognition with me. Okay, let's talk a little bit about technology. I'm sure many of you are very familiar with navigating Zoom at this point in time, but I'm going to very briefly review how we will be using these various functions for today's workshop. So starting from left to right on your Zoom panel, for audio, you can click the microphone icon for more settings and options. To unmute while speaking, you can press and hold the space bar. And just a reminder, during our time together as we are practicing mindfulness, when you are listening or others are speaking, please keep yourself muted and of course unmute if you are about to speak. Then we've got the video camera icon. Feel free to turn your camera on for today's workshop. We'd love to see you all. If you'd like to update your name being displayed or to add your pronouns, please go ahead. Go ahead and click Participants, hover over your name, select More, then select Rename. That's where you can update your name being displayed for everyone. And then we've got the chat box. We're definitely going to be using our chat box in today's workshop. This is where you can share questions and answers and such, especially if you are not able to use your microphone. This is also where you can send me a private message if you need to. To do so, click the drop-down button that says To Everyone and select Emily Sulpizio. If you're having any tech challenges, let me know and I'll be happy to help. We also then have our Reactions tab. This is where you can express yourself with a hand raise, a clap hand, or whatever you resonate with. All right. Just a couple of important things to note about this workshop. We'll be doing a short live feedback at the end of the day to gather your opinions on the workshop. So please keep that in mind as you are experiencing today's session. And then lastly, as we all know, technical glitches are inevitable. So in the event that something of that nature occurs during today's session, we just want to thank you in advance for your patience and understanding. All right, thank you all so much for listening. And again, welcome to today's workshop. I will go ahead and turn things over to Megan Juring.
Good morning, everybody, and thank you, Emily. I'm Megan Juring, the coordinator for the APS Leaders Institute. My pronouns are she, her, and I am joining you from the Nishanan land in the Sacramento area. In addition to Emily Sulpizio, who you've met, I'm joined by colleagues at the APS Workforce Innovations, Callie Fleckner and Kat Preston Wager. We are excited to have you here today and are here to support you and the presenters throughout the workshop. As Emily mentioned, we do appreciate having your cameras on so that the presenters can see your faces. It really helps with their engagement and yours. In case you're new to the Leaders Institute workshops, our goal is to support APS and adult service leaders throughout the counties in California and enhance your capacity to drive program improvement locally. We do this through workshops like this, through connections with knowledgeable presenters like today's, and facilitating connections between you all. Today's topic is including older adults in county behavioral health planning. I feel like that's the part where it's like, if you're on the wrong plane, exit now. But I see we have a really great turnout and a lot of interest in today's topic. It's timely given the passage of the Behavioral Health Services Act recently and Proposition 1, which guides the funding for those monies. It's also connected to California's Master Plan for Aging, which is a topic that ranked high on our needs assessment for the current fiscal year. Our presenters include two leaders of the California Department of Aging, Sarah Steenhausen and Anna Acton, as well as Dr. LeOndra Harvey, who is the CEO of the California Behavioral Health Association. I'll introduce them further when we turn it over to the content. We're on the agenda slide right now, and clearly we're in the welcoming and opening remarks section. Following that, we'll be diving into the content with the workshop presentations from our speakers, and then we will have what we hope to be a very robust Q&A discussion. I want to mention here that we are not going to be breaking out into small groups for this topic. We want to stay together as a group for this Q&A and really focus that discussion. So it's kind of more than just a Q&A. It's really kind of our time to discuss the topic, as it's pretty new to have requirements to include older adult and service providers for them in the planning process. We are asking you to hold your questions for the Q&A session, but if you have a question about a specific slide, please do mention it in the chat and we'll flag it to bring it up. And we've also planned some time for a debrief to gather takeaways. I guess that's showing kind of as a closing summary. Like, what are your main takeaways and thoughts about what might be your next steps in terms of the content from today? I also want to mention that we will be taking a short 5-minute comfort break roughly midway through. So we'll see how the flow is going and give everyone a break. As Emily mentioned, we will be seeking your evaluations at the end of our time. Live feedback, what worked, what might we incorporate changes to for our next workshops, and also a structured end of day survey, which will drop in a link so that you can spend our last minutes together completing that survey. Both elements are really important to us because we really do take that information, look at it, and build it into our planning for the future. You probably heard and or saw the notification about the workshop being recorded. We will be stopping the recording before the Q&A session. So we want your honest feedback for the evaluation. We want your questions and frank discussion, and don't want anything to impede that. And now I'm pleased to turn things over to our fabulous presenters to dig into today's content. From Department of Aging, I mentioned we've got Sarah Steenhausen. She's the Deputy Director of Policy, Research, and Engagement at California Department of Aging. Had an opportunity to work with Sarah for many, many years. And she really is someone who brings her whole career in policy and programmatic areas for the older adults in California. And with her, we've got Acton, who's the Assistant Deputy Director of Policy, Research, and Engagement at Department of Aging. I've also had the pleasure of working with Anna for many years, and her career really brings to us the nexus between disability and aging from nonprofit management and programmatic experience, as well as state government and policy. And Anna introduced me to Dr. LeOndra Harvey, who's the Chief Executive Officer at the California Behavioral Health Association, and also has a dual role as the Executive Director of the California Access Coalition. Her wealth of experience, really brings to light the perspective of the behavioral health side of the house, and her membership includes community-based providers all across the state. So we are just really fortunate today. And I encourage you to review their bios, which is on our website and should have been included with your registration materials. So we'll start with Department of Aging, and I understand Anna will be kicking us off, and Sarah will join in. Thank you, ladies. The floor is yours.
Thank you so much. And it is actually really wonderful to be here with all of you to talk about this really important issue around access to behavioral health services and the opportunities that are coming up for those within the aging networks, disability networks, and the APS networks with Proposition 1 and the Behavioral Health Services Act. So we'll go to the next slide. So I'm really excited to be here today. Megan mentioned that I've had some local experience working with nonprofits, providing services to people with disabilities and older adults. And then for the last few years working with the state of California, it's really been amazing experience having both lenses and views and be able to really see what we can do to ensure that older adults, people with disabilities, and caregivers get access to the services they need, including behavioral health services. So today we're going to go over a little bit about what the issue is around older adult behavioral health, which I really could turn this over to you, and you could probably actually tell us about the issues that you see at the local level, because I know each of you, whether it's yourself or your team, is really on the front lines of supporting individuals who are experiencing behavioral health issues, right? Whether it's isolation and loneliness or it's more significant behavioral health issues, this is the work that you do. So I'm sure you could do this training and really talk about what those issues and impacts are. We're then going to go over, I'll turn it over to Sarah to talk about Proposition 1 and the Behavioral Health Services Act, or BHSA as we refer to it, and kind of where the opportunities are there to really see where we can help coordinate and support at the local level to ensure people get access to those services locally. She'll go over the state role and county role, and then, of course, the need for advocacy around access to behavioral health services. So we'll go to the next slide. So I'm going to start with the unmet need. Again, this is something that all of you really are living and breathing and working with yourself or your teams about really working to address those unmet needs of older adults and people with disabilities with behavioral health needs. We know through research that close to half of all Americans have experienced a diagnosable behavioral health disorder by the age of 75. But we also see that less than 1/3 of those older adults in need of mental health services actually receive appropriate care. We know that older adults 65 and plus are least likely to both report receiving mental health care compared to all other groups. So I know you see that unmet need at the local level, and we're going to talk a little bit about a couple of the other pieces on this, both stigma, suicide rates, social isolation, and of course, looking at it from an equity lens. So we'll go on to the next slide. So stigma, right? We know that there are definitely issues with stigma around behavioral health, around mental health. We see this play out in the media. We see the public's perception around mental health, and we see that play out in negative beliefs, attitudes, perceptions about mental health illness, which again leads to stereotyping, prejudice, and discrimination towards people with mental health disorders. We see this play out in the media. We see it play out in our local communities. We also know that there's the internalized stigma, right? So many individuals may feel internalized stigma around mental health, being afraid or shameful of disclosing that they have a mental health disability because the way they may be perceived or think they may be perceived if they disclose that. We see that play out in the workplace, in the community, and accessing services. So we also know that sometimes this leads to people, kind of anticipated stigma, being concerned that if they disclose, if they're open about their mental health, that they may, face discrimination in the future because of that. So we really see this public and internalized stigma can really lead to a reluctance for individuals to reach out to seek help, both mental health treatment, and we also see this especially among certain minority populations. We see that there are distinct cultural differences in how various groups approach mental health care. You've probably experienced this yourself at a local level. You may see that Asian Americans may be more hesitant to discuss mental health issues with anyone due to cultural stigma. We see that Latinos are generally more open to consulting a psychiatrist, but less likely to engage with a medical doctor for mental health concerns. And we see the impact of stigma on mental health treatment use, especially pronounced among African American and Asian American Californians. So we really see that this stigma can really be a barrier, right, for individuals to seek services and access services. And again, it may be different depending on cultural perceptions around behavioral health and how that may impact their interest or ability to seek those services. We'll go to the next slide. Suicide rates. We see that suicide rates are a significant concern, and especially for older adults. We see that suicide rates climb among older adults in general. And if any of you have had a chance to look at the California Department of Public Health, they often do a report on suicide rates in California. In 2018, which I think they're going to be publishing the new data really soon. In 2018, there were over almost 4,500 suicide deaths among California residents, with 21% being individuals who are older adults. So we really see a lot of older adults in the data. And we see that approximately 83% of older adult suicides are males. 46% of those were among veterans. And so for males, the suicide rate increased with age and was nearly 10 times the rate of females in individuals aged 85 and older. So we know that this is definitely an issue for older adults. And we'll go to the next slide. So social isolation and loneliness for older adults is really becomes an issue. Also provides serious health risks that puts individuals at risk of dementia and other chronic conditions. Working at the local level, we saw in rural communities in my past, I've seen a lot of social isolation issues and the real intersection that it has on individuals' mental health, behavioral health, but also just in their overall well-being and connection to community. We know that individuals can be isolated physically, not really surrounded by many individuals. Maybe they live in a rural community, maybe they live in an urban setting, but are still not really connected with other individuals. But we also see kind of social isolation where people may be surrounded by individuals, but still feel very isolated and lonely. So the National Institute on Aging reports the health risks of prolonged isolation are equivalent to smoking 15 cigarettes a day. So just putting that connection with isolation and loneliness with your physical and overall health and well-being. In California, changing family systems, I would say, have exacerbated isolation among older adults. We have a growing childless older adult population that's happening. And we know that this really can lead to this social isolation, loneliness, and overall behavioral health issues. We know also that individuals, older adults who are isolated and lonely might also be more vulnerable to abuse and fraud. If you're isolated, you might be more willing to give up your credentials or talk to people you shouldn't be talking about. And I'm sure all of you deal with this on a daily basis, this connection with isolation and loneliness and being more susceptible to fraud and abuse. So I'm going to go on to the next slide. So the California Department of Aging in 2023 did a community assessment survey for older adults and found that of this over 17,000 individuals surveyed of older adults, 40% reported feeling lonely or isolated and that it was a problem. And 43% reported feeling depressed and nearly half were dealing with recent grief or loss. This is an issue that I'm sure all of you can relate to and deal with firsthand on a daily basis in the work that you do. We'll go on to the next slide. We also did California's first statewide study of LGBTQ older adults, where we surveyed over 4,000 um, older adults that were surveyed and found that nearly half had experienced a traumatic event in their life. 1 in 4 had symptoms consistent with post-traumatic stress disorder, and 1 in 10 reported serious thoughts of suicide in the past year. So, equity considerations are really a concern and something to be aware of. Among older adults, there are critical equity considerations to elevate. With Black, Latino, Indigenous, Asian Pacific Islander older adults, they are more likely than their white counterparts to report high levels of psychological distress and serious mental illness. Likewise, data really suggests that the LGBTQ community, like I just mentioned, and older adults from that community experience higher rates of mental distress than heterosexuals of the similar age. And in addition, we see that race, ethnicity, sexual orientation, and gender identity, older adults in rural communities specifically face unique challenges and barriers to mental health services and supports. So equity really does impact these discussions. So we'll go to the next piece, and I mentioned it already, the California's first statewide study of LGBTQIA older adults, again, backed up, right, that nearly half have experienced a traumatic event in their lifetime. So we'll go on to the next slide. And we wanted to elevate a recent, just last year, we worked with Insure the Uninsured Project and on a surveying 225 local, state, government, nonprofits, community organization, and health plans. Maybe some of you were surveyed as part of this as well. And what we found, and this probably is going to resonate, that the number one challenge reported from the 225 local entities is that social isolation and loneliness is the number one challenge for local communities for older adults. We also found that the number one service gap was lack of behavioral health services that are focused on older adults and are kind of responsive to the needs of older adults in the local communities. And we found that 6%, over 50% believe that behavioral health services should be delivered where older adults gather, right? Think about that. And I bet that some of you have solutions where you are going to where people are and connecting with them where they are in their gathering, but that's really an opportunity as well, right? To be able to meet people where they're at to ensure they get access to the services that they need. So that gives us a little bit of an overview of some of the challenges, the problems that we see with older adult behavioral health issues and access to services. But I'll go to the next slide and talk about where there's also some opportunities before I pass it on to Sarah. So, and these are opportunities really focused on meeting the older behavioral health needs in our local communities. So in 2024, CDA partnered with U.S. International Media and NORC at the University of Chicago to commission a literature review to explore concepts related to behavioral health among older adults, specifically among groups experiencing disparities, with really the goal of supporting development of communication strategies and kind of opportunities for further research, refinement, and future communications around this particular topic of older adult behavioral health. We found that there's really an opportunity on focusing on resiliency, meaning communities with increased resiliency have an inverse impact on levels of depression and loneliness, and really effective coping strategies can significantly enhance the well-being of older adults. We also saw an opportunity with addressing that stigma that we talked about earlier, right? If we can increase awareness and include family members and other support systems and communication and in addressing stigma around older adults and behavioral health, that would really help with creating more opportunity for accessing services and being more resilient as individuals and communities. We also found opportunities to tailor our messaging, right? If you're outreaching, if you're doing communication, are you tailoring those messages to ensure that the communication you're putting out there resonates appropriately with older adults? Is there targeted older adult messaging specifically to really ensure it, speaks to the intended audience? There's really an opportunity to encourage recognition of the need, right? Raising awareness, not being afraid to talk about older adult and behavioral health needs, and really increasing information seeking and help individuals really be able to reach out to seek those treatment and those behavioral health services specifically. And then really looking at how to increase social support, social cohesion, and social connectedness. I know many of you have these kind of programs or work with nonprofits and organizations that are really doing some amazing work to bring older adults together, to reduce isolation and decrease loneliness, and really thinking about those opportunities and how it plays in to the larger behavioral health spectrum of supports and services that keep people living in the community and connected to their family, friends, and community at large. So with that, I'm going to pass it on to Sarah, my esteemed colleague. And before I do, I just want to thank you all for the work that you do. Again, I know you're dealing with these issues that I've kind of briefly gone over here around the problem with older adult behavioral health, but you're really on the ground level and you're seeing this every day. And so hopefully we'll have some good discussion at Q&A as well. So Sarah, take it away.
Great. Well, thank you so much, Anna. And I also want to just echo Anna's appreciation. I know that a lot of the older adults that you work with are probably, many of them are on more like a significant level of need in terms of behavioral health issues that they face. And so the behavioral health the state's effort to implement behavioral health transformation, I think provides us a new opportunity to consider how local networks can better serve older adults. Because when the Mental Health Services Act was implemented, I think that in general, the aging network really lost an opportunity to elevate the importance of addressing older adult behavioral health. Many, of the reasons that Anna outlined, I think really explain why we have a far way to go to address the needs of older adults and behavioral health. Next slide, please. So I wanted to provide first an overview of the efforts that the state implemented to modernize the behavioral health delivery system. In March of 2024, California voters passed Proposition 1, which included both the Behavioral Health Infrastructure Bond Act, which provided over $6 billion for the construction and rehabilitation of behavioral health treatment beds, supportive housing units, and community sites. Additionally, the legislature passed the Behavioral Health Services Act that, as I said, reforms the Mental Health Services Act, which was originally passed in 2004. It includes expanded services to include treatment for substance use disorder. It modernizes county funding allocations, and it updates reporting requirements to focus on outcomes, accountability, and equity. And I will walk through today primarily what the Behavioral Health Services Act includes and where there might be opportunities for you and your network. I also want to note that we're really happy that LeOndra Harvey is here, because her focus is going to be on what is called the full service partnerships, which really address the mental health needs of people with more serious mental illness. And I think that might be where there is opportunity for adult protective services to engage in full services partnerships at the local level. So we're going to give you an overview of where the opportunities are and how you might play a role. Next slide, please. So in general, in the Behavioral Health Services Act, there have been several changes, but the prevention funding. So prevention funding is for services such as fighting isolation and loneliness. It's population-based prevention. So for older adults, we really see the opportunity to address a lot of the loneliness, the isolation that Anna was speaking to. And these opportunities are funded at the state level now through Department of Public Health. Previously, the counties played a role in both prevention and early intervention funding, but with the Behavioral Health Services Act, it's kind of separated out the funding from Department of Public Health is now responsible for prevention, and the local levels at the county are responsible for early intervention, along with other services that I will outline. The Behavioral Health Services Act also now enables counties to fund treatment of substance use disorder services. And also we will talk a bit about their funding of early intervention programs. What's really exciting is that there are also opportunities to support the housing needs of those with serious mental illness. And I'm highlighting this because I think, APS with the Home Safe program has seen, the importance of providing a range of services to address the needs of the APS population. And with Home Safe not being extended beyond its current funding capacity, there might be opportunities to look at how at the local level you might be able to address some of the housing needs of your clients through these opportunities. And then finally, as I noted, full service partnerships, which are for people with more of the severe mental health needs that provide a lot of the wraparound services that are needed and kind of approaching the whole needs of the individual. LeOndra Clark Harvey will be speaking to where there are opportunities in that space. Next slide, please. So I wanted to first outline the state's role in Behavioral Health Services Act implementation so that you can understand which entities are responsible for which components. Next slide, please. So Department of Health Care Services is the entity that has the lead oversight and implementation of the whole Behavioral Health Services Act. There's a significant amount of funding that is going for workforce initiatives. Obviously, workforce is critical to addressing the needs of people with behavioral health. And the Department of Healthcare Access and Information has a number of initiatives underway to address behavioral health needs of to train the workforce across the continuum. As I noted, the Department of Public Health is responsible for funding population-based prevention services for children, family, and older adults. And then Department of Healthcare Services is responsible for developing outcome measures to look at what impact this funding is having on people's mental health status. I will note that, this Behavioral Health Services Act provides a really important opportunity to understand how counties are funding behavioral health services. Previously, the state did not play a role in reviewing each of the counties' behavioral health plans. Now, with the Behavioral Health Services Act, the counties are going to be required to submit their integrated plan to the state in March of this year. And so they're going to have to outline a number of different funding streams and how they're funding the behavioral health needs of their population. At that point, the public can comment on the county's proposed plan, and then the state reviews it and then works with that county to determine if there are tweaks that are needed to their plan and different ways that they may be able to meet the funding needs of the population at the local level. So this is a really new opportunity for kind of a level of transparency in implementing the Behavioral Health Services Act so that at the state level, we can have a sense of how all populations' needs are being met at the county level. We're particularly excited about this because, as we said, we think that older adults have not always been a key target population of Behavioral Health Service Act implementation at the local level. And we really want to shine a light on the needs of this population and ensure that they're getting their fair share at both the state and local level. Next slide, please. So now I'm going to focus on the county's role in Behavioral Health Services Act implementation. Next slide. So the counties actually receive 90% of all of the Behavioral Health Services Act funding. So that funding is divided into 3 buckets. First is the Housing Interventions Program. And we're not going to be going into great detail on that today, but if you're interested in more information, we can send you the links to how you can learn more about where those opportunities might be. As I said, I think this could be critical for helping identify ways to support the housing needs of the population you serve. 35% of the funding goes to full service partnerships, which, as I noted, LeOndra will be speaking a lot to in her remarks, and those address the needs of people with more serious mental health issues. Finally, I'm going to be talking a bit more about the behavioral health services and supports and how that funding is distributed. And again, that's 35% of the county funding goes to the behavioral health services and supports. Next slide, please. So as I said, the focus on behavioral health services and supports. So of that 35% that counties have to spend on behavioral health services and supports, at least 51% has to be used for early intervention programs and services. So what are earlier intervention programs and services? Early intervention are for people who might have treatable mental health services at the kind of maybe depression or anxiety that, if addressed early in the stage, can be mitigated and actually can see a lot of improvement so that they don't continue increasing their need for mental health services. So again, we want to make sure that for older adults who have depression or anxiety that could be the result of many different factors in their lives, that they get early intervention so that those issues can be treated early and often and then mitigated from getting worse. Another 51% of all the funding for early intervention has to go to serve people 25 years of age and younger. So I think when the Behavioral Health Services Act was being debated at the state level, there was concern among advocates of children's, youth, and families that the funding that was targeted for youth and children would be lost if there wasn't a set aside amount. So the state determined that 51% of the funding has to go to those 25 years in age and younger. What we want to make sure is that the remaining 49% of funding for early intervention programs also strongly includes representation for older adult programs and services. Next slide. So as I noted, counties are required to establish early intervention programs. And these are, as I said, the programs that are designed to prevent mental illness from getting worse, as well as substance use disorder from becoming severe and disabling, while also addressing the disparities in the behavioral health outcomes. This includes outreach to individuals and community, helping individuals access and link to the medically necessary care, and, as I said, treatment aimed at preventing the progression of behavioral health conditions. So there are some examples of early intervention programs that target older adults. These include programs like PEARLS. I don't know if you've heard of PEARLS, but PEARLS is a program at the that we've heard of several counties implementing previously through the Mental Health Services Act that treats depression in older adults through an evidence-based program model. And it's an excellent program that we're hoping can be replicated in many counties across the state. There's a number of other early intervention programs, but I won't take the time right now to walk through them. We have a toolkit that I'll talk about that outlines what those program models are and how counties can advance them. Next slide, please. So as I noted, counties are required now in the Behavioral Health Services Act to develop integrated plans that weaves together all the funding and different funding streams for behavioral health services. In developing those integrated plans, counties are required to engage local stakeholders for each element of their plan. So required stakeholder groups include people with lived experience, including older adults and caregivers, area agencies on aging, independent living centers, community-based organizations, as well as behavioral health providers, peers, and workforce representatives. Next slide, please. So we developed a toolkit, and I'll make sure either Anna or I can put the link to our toolkit in the chat. We felt that as we were trying to raise awareness about the opportunities for older adult investments in the Behavioral Health Services Act, many of our partners in the Aging Network were not familiar with or engaged in the Behavioral Health Services Act. For years, they've kind of not really known what role they could play. So we developed a toolkit that's individualized for each of our 58 counties that outlines what the Behavioral Health Services Act is, where older adult investments can be focused, and what examples there are of programs, particularly with a focus on early intervention. So that's, as I said, you can get more information. Anna just put the link up in the chat if you want to peruse the toolkit. Next slide, please. As I said, at the state level, there's opportunities to influence the implementation of the Behavioral Health Services Act, and this is outlined in our toolkit. Many common opportunities through many different policy initiatives across Department of Healthcare Services, Department of Public Health, which, as I said, focuses more on the population-based prevention services, and then also the Department of Healthcare Access and Information for its workforce initiatives, including opportunities for community health workers and funding focused in that space. Next slide. We see a lot of intersections in terms of investments in older adult behavioral health. It's really important to think about the role of family caregivers, who are often also older adults. Family caregivers are unpaid individuals who provide a bulk of the care to older adults in their home and the community. But oftentimes they are suffering from isolation, loneliness, or depression. And we want to ensure that they also have the opportunity to address their behavioral health needs. Of course, a really important intersection is the unhoused older adults and those at risk of homelessness. This is exactly the population that many of you serve. So we see tremendous opportunity now with the investments into housing and to substance use disorder and others to partially address the needs of this population, at least through some investments in housing services, as well as funding for older adults who are at risk of institutionalization and veterans. Next slide, please. So as we have a number of resources, Anna put up that link to our Behavioral Health Services Act toolkit, but there also is a friendship line, which is a 24/7 warm line for adults age 60 and older, as well as adults with disabilities and their caregivers. And we can put a link up to that. This is a really critical service that is for any older adult who might be feeling lonely or isolated. It's a wonderful warm line that is operated through the Institute on Aging, and we just encourage you to offer this as a resource to the people that you serve. Finally, I just want to note that we have developed a landscape of California's home and community-based services that outlines which services are available in your counties. It is not a consumer-facing website by any means. It's really designed for people like yourself who are service providers or policymakers and want to understand where services are in the county level that provide services, a range of services to older adults, people with disabilities, and caregivers. Anna just put the link up to the friendship line, and we can also put a link up to, there's the digital landscape. Thank you, Anna. So that wraps up my presentation. And I don't know, Megan, do you want me to hand it directly over to LeOndra, or do you want us to take a break now?
Oh, thank you so much, Sarah and Anna. That was a lot of information and really useful links and ways for people to research more and dig deeper, specific to the services in your county. LeOndra, let me ask you, break or dive in?
I'm ready to go. I'm ready to go if you are.
All right, let's do it. I think folks are up for another few minutes here.
Awesome. Awesome. Well, thanks everybody for the invitation. I'm so honored to be here and talk about what I'm calling opportunities for collaboration. I think there are many, and we know that sometimes crisis is what allows us to come together and put our best thinking caps on. Right now, our system, our nation is under a lot of stress that's trickling down to the work that you're doing on the ground every day. So I want to start off with appreciation and praise for the work that you do day in and day out. You are working with some of the most vulnerable individuals, but also some of the strongest people. If you think about the older adults that you work with, these folks have fought wars. They have been unhoused. They have raised generations of families. So these are our leaders. And I really appreciate your commitment to keeping them safe and healthy and strong. And that includes their behavioral health. That's often something that's treated as an add-on or a luxury if you get to address that, but it's so integral and important. So thank you for the hard work you do. I'm Dr. LeOndra Harvey. I am a psychologist by training, and I have the privilege, and when I say privilege, I really say that seriously, of being the Chief Executive Officer of the California Behavioral Health Association. So our organization represents a little bit of everybody. We're the most diverse provider association, advocacy association in the state of California. Collectively, our diverse members serve over 2 million Californians every year. So from a small agency that's in a rural county doing most of the mental health and substance use disorder to large conglomerates that have presence in 30 plus counties, right? Providing lots of different services. So on the slide, I've shared a little bit of the diversity of services that our members provide. They are community-based organizations, for-profit and not-for-profit. Many, about 25%, are also federally qualified health centers. We have about half of the state's 20 CCBHCs. That stands for Certified Community Behavioral Health Clinics. It's a new model. It's akin to a FQHC lookalike for behavioral health, and that's funded by a SAMHSA grant. We have hospitals, inpatient facilities for behavioral health. We have probably about a third of the 98 call centers in the state belong to our association. We have foster family agencies. They have a little bit of everybody is here, and we love our big collective family because it allows us to have insight to various different perspectives of what is happening on the ground in terms of service provision. And our members serve the full spectrum. There's programs for mothers who are pregnant all the way to end of life. And we have agency that specifically their mission is serving older adults. So I want to talk to you a little bit about what we are seeing with behavioral health providers and the opportunities to connect with other systems. Because as I mentioned, a good crisis drives us all to be more creative in how we think and how we collaborate. And so I don't have a ton of time here, but I will share just some ideas on how you might work more collaboratively and intentionally and strategically with the community-based organizations that are providing behavioral health services. So let's get to it. All right. APS and behavioral health providers often serve the same people, right? The same older adults, but really from different entry points in the system. But the truth is that they're all contending. These clients are all contending with the same social drivers, right? The same social determinants of health. And that was outlined in the prior presentations, whether it's stigma, lack of community support, lack of education, resources, nutrition. This is the same individual, yet they're having to navigate a system with lots of different entry points. And so that's why today's conversation is really important around how we can leverage the Behavioral Health Services Act funding to really intentionally align the systems, because we know that when systems are aligned, that this can lead to improved safety and stability for older adults, which is part of the mission of the work that you're doing, right? We know that crises can also be reduced and system fragmentation can be kind of healed, right? We can put some super glue on those cracks. We also know it's important to support aging in place with dignity, right? There's a lot of aging in place happening, but it's not a dignified process for many individuals. And so that's why it's important to talk about how we can collaborate to ensure that that's happening in the way that most of our organizations have envisioned for that to be. And then also we want to talk about the importance of strengthening countywide care coordination. That's really what it comes down to. So I just want to commend my colleagues from CDA who just presented for doing a stellar job reviewing behavioral health and everything that the state and the infrastructure that we have to work from. And so I've been asked to focus specifically on a model that can be leveraged to really promote synergy, really, between APS workers and behavioral health community based organizations. And that is a full service partnership model. Now, full service partnerships really came about around, I would say late 90s when the Mental Health Services Act was being conceptualized. So CBHA's founder, Rusty Seelix, worked with Daryl Steinberg to draft the Mental Health Services Act. And full service partnerships became one of the flagship models of that funding. And we know that today that the Mental Health Services Act, now the Behavioral Health Services Act, funds the lion's share of county behavioral health services, public behavioral health services. And so I think that the writers of the act did not anticipate that when they were writing it. They thought this would be a great pilot project and some funds to serve folks. And it has really turned into this very important instrumental landmark in how services are provided to public recipients of behavioral health services. So let's talk about what FSP is. I'm a visual learner, so I tried to put some color here and also just kind of illustrate all of the pieces. The kind of catchphrase of FSP or full service partnerships has always been, it's a whatever it takes model. And that's because we know that with vulnerable populations, you have to be flexible. You have to be willing to pivot. And you all know this because you are working in the trenches. You are working with people and their needs that are impacted by all those social drivers. They can't be predicted. You don't know what's going to happen. And as a psychologist and someone that used to work in the community, you go in and you're just open to all of the different possible realities that you are going to face as you help someone get help. So full service partnerships are really intended to be intensive and integrated. The idea is to offer a comprehensive, really kind of a spectrum of services. So this could include therapy, medication, case management, linkage to maybe housing or employment. And specifically, this model is for those that are diagnosed with an SMI or serious mental illness. So again, it's a whatever it takes approach. It's flexible. And what's really great about this and why this has been really one of the hallmarks and flagship programs of the Act is that it is flexible. It's client driven. That's really the philosophy that's behind it. And the idea is to really meet the individual needs and goals, promoting recovery and wellness. So it's really important to understand these components, and that is why it's successful. That's why we're highlighting it today. So as you'll see here, there's a few different areas called out is a low staff to client ratio. This is a tenet of the model because it ensures personalized care with this kind of dedicated team around the individual. And this can include peer supporters, clinicians. There's also a tenet here around crisis support, 24/7 crisis support so that there's immediate assistance for crises in the community settings, right? Going to where a person is at. There's a focus on the unhoused population. So part of the tenet of the model is to target individuals who are at risk, unhoused, and provide critical housing access and support as well. And then there's also, as you can see, a community-based services piece of it. The services must be delivered in the community, often in the client's home if they have a home. And the idea is to really reduce reliance on restrictive settings like hospitals. Nothing wrong with hospitals, and yet this model is really around community-based care. So hopefully you got all of that. Don't worry, the slides will be provided for you later. But I want to share with you where these amazing full service partnerships are at in our state. And I'll share with you quickly, there are 8 and about three of them are our members, right? And the rest are pretty much county run. And it's when I ask people and I tell them, hey, did you know there's older adult specific full service partnerships? Most folks are like, really? I didn't know that. Where? And that's concerning because this is really important. And yet, when you look at the number of full service partnerships in our state, the older adult specific ones are clearly the minority. And so that's why I want to raise them up and I want to make sure that they are on your radar. They may be already, but it's also good to know where the next one is outside of your county, right? We know clients move around a lot. So understanding what the network looks like, where they're at is important. So I'm going to show you the list. Excuse me. And I'm going to walk through a little bit of what they do because there are different ways of designing full service partnerships and they don't have to offer, they may offer different elements or different tenets of this model. And so that's what we'll do next. So here we go. Here are all the logos of the 8 older adult specific full service partnership programs, which I just love. I love that this population is really driving counties and county behavioral health organizations to come together and provide the specific service. So let's see, these FSPs specifically serve adults that are 60 and over, okay? And so counties with larger behavioral health systems, for example, Los Angeles, Sacramento, and Riverside, they may have multiple full service partnership teams, and they can include services for older adults, even if the name doesn't say older adult FSP. So you see a lot of county logos on here, and they don't say adult FSPs, but they do provide that service. So 3 are run by community-based organizations, as I mentioned. That is San Fernando Valley Community Mental Health Center, El Hogar, and Felton Institute. Felton Institute is in the Bay Area. El Hogar is in Sacramento, and obviously San Fernando Valley Center is in San Fernando Valley. 4 are also run by counties, and then 1 is run by a hospital system. So you'll see Riverside University Health Systems. So I'm going to talk about these, and then I'm going to dig in a little bit more around our local, for me, local, in Sacramento, FSP, which is El Hogar. So in Napa County, their older adult full service partnership provides intensive services for those with mental illness. And what they provide is counseling. They also provide housing support, substance abuse treatment, and wellness planning. I love that piece, wellness planning. I wanted to call that out because so often we're working on the issues that are coming up and we're chasing the crises, but wellness planning is a big part of this, right? Looking forward to how you are coping and healing and including community. I heard my colleague earlier talk about the importance of family and supports. And so when you're doing that wellness planning, you're able to bring in those supports and families to help you with that. In San Fernando Valley, this is a LA area based, they provide intensive mental health treatment, and they also provide case management services. The one in San Luis Obispo provides an intervention team for adults. And so they're promoting wellness and community living by going out in these intervention teams. Felton Institute in San Francisco, they provide also medication support. They have a crisis intervention arm to their FSPs, housing linkage, job stability, etc. Services that way as well. And then the Riverside University Health System, they are really focusing in on those that have a hospitalization risk because they provide those services naturally. And what else can I tell you? Oh, in Los Angeles department, they have multiple service areas. So they have a lot of different areas and they have FSP teams as well. And then the Tri-City program is really around Pomona and the surrounding areas. And they also provide intensive crisis support and FSP services for older adults. So these are the folks that are doing the work. They may be in your areas, but they think that there's a lot of opportunities to work with them and to lift up their work, especially considering there are only 8 in our state. All right. So I want to take a little bit of a closer look at El Hogar because it's here in my neighborhood. I've visited them and they do some really great work. As you see on the right-hand side, this is a list of services, and I'm highlighting them because they're doing a lot over here. At the same time, I will be very transparent. Their funding is at risk and they are concerned. I just spoke to them yesterday around the ability to continue providing this FSP services to older adults. And so this is when we really need to think about how can we work together to ensure that those in our, service provision areas are supported. How can we leverage funds and expertise and teams to support the older adults? Because if this program goes away, then we are in serious trouble here in Sacramento County, because as you know, there's only 8, and the next one isn't very close to us. And so we want to make sure that we're thinking about being creative and strategic in order to secure services. So as you see, they do geriatric assessments, they do rehab and therapy, advocacy, housing, a little bit of everything. So I think this is really a flagship, FSP to highlight. We're really proud of their work, and this just gives you a look at all of the diversity of services they provide. They even provide transportation. So this is what FSPs do. This is an FSP that is very much taking advantage of everything they can to provide services in lots of different ways because everyone's different and everyone has different needs. So I wanted to share a number of ways that APS workers can work together with community-based organizations to provide services. So let's get to it. The goal really here is around funding to better coordinate care for older adults. And what I've done is I've framed these to align really with BHSA priorities, the Behavioral Health Service Act priorities, CalAIM, and also county operational realities. So I tried to include some low-hanging fruit examples, things that you could maybe work on tomorrow or today if you're ambitious, and things that you really want to think about long-term in terms of how the cross systems come together to really brainstorm. So this first slide is on cross-system coordination and infrastructure. So BHSA funds can be utilized in terms of how you look at your joint older adult teams. You know what you do. You have your teams, but are there teams within the community-based organizations that are, working with the FSPs that can join with your teams? There may be an ability to utilize the BHSA funding to support kind of a multidisciplinary team. This could include APS worker, a social worker, a behavioral health clinician, a peer specialist, a care coordinator. There are opportunities to come together and really focus on those high-risk adults that are experiencing self-neglect, abuse, exploitation, serious mental illness, and cognitive impairment, because we know that many of those run together. Also, there are experiments around co-locating teams, right? So you can co-locate your staff with a behavioral health community-based organization or county-run FSP staff. And this will allow also for sharing of funding. There can be funding to embed behavioral health clinicians within APS units as well, or vice versa. It also enables a very natural, warm handoff process. You could share assessments, and it allows you to respond faster to crises. The other point here is around shared intake and referral pathways. We know that paperwork is burdensome. Paperwork reduction is something that my members are always striving for, and it is the number one issue when I ask them, what is keeping you up at night? It's paperwork reduction or administrative burden and workforce issues. So these strategies are ways to combine our workforce and decrease our paperwork, thank goodness, right? So the standardized assessment that could be developed could include coming together around referral protocols, really whatever works with the infrastructure for both groups. And it really helps prioritize older adults with repeated APS reports, hospitalization, or housing instability. Because we know there are what we sometimes call internally generally frequent flyers, people that are coming in often to use services. And so thinking about how we can serve them, how you can serve them in a way that's more coordinated and efficient. And then I also put here data sharing. So there can be funds to support shared coordination within legal privacy limits, of course. This allows us to track risk factors, service engagement, crisis history, and care plans across the system. All right, let me try to get through the rest of this. Around service delivery and program design, I wanted to highlight a few things. Really want to look at how to link older adult full services to APS, focusing on the crisis response. Okay, so here you'll see care transitions, APS referrals, crisis response. There are a lot of opportunities to join together here. We could coordinate around mobile crisis teams, right? That can be funded through the Behavioral Health Services Act, and there could be a joint response from APS when you have elder abuse, self-neglect, or grave disability. When that's suspected, there can be joint teams that are flagged and work together. This also helps to reduce unnecessary law enforcement or ED involvement. Around the trauma-informed behavioral health services for clients, we could use funds to expand access to geriatric psychiatry, therapy, substance abuse treatment, and older adults as well. So just want you all to think about that. Want you to think about the transitions that happen. APS and behavioral health workers could also collaborate on BHSA-funded transition support. And this is a prevention effort to prevent re-reporting, rehospitalization, and institutionalization as well. So including, medication reconciliation, follow-up appointments, in-home supports, all of those things can be a part of what you're looking at when you're developing the care transition with the community-based organizations and other entities. Workforce development and training. We can do some cross-training. We could use the BHSA workforce funding, their specific workforce funding, to fund APS workers getting more training on serious mental illness, substance use disorders, dementia, behavioral systems. And we could train behavioral health staff on elder abuse laws, APS mandates, all the things that you're expert in, conservatorship and capacity issues. So we don't need to stay in our silos. BHSA funding can be leveraged to do that cross-training and to be more effective, efficient, and collaborative as a system. Also want to share around workforce expansion. Funds could be invested in recruiting and retaining clinicians with geriatric expertise. There's a lot of clinicians there, right? But if they don't have the expertise for working with the population, you're going to spend a lot more time doing the training, bringing folks up to speed. Funds around workforce with BHSA can also be utilized to support loan repayment, stipends, supervision for staff serving APS-involved older adults. There's a lot of opportunities here. And then we talked a bit about peer and family support. Did you know that funds could also be used to help with peer and family support between community-based organizations and APS workers? And this is, as we shared already, to reduce isolation, to improve trust, which is really critical with this population and their community, and engage and improve engagement. Want to talk real quick about housing, safety and stabilization, and some opportunities there. So around permanent supportive housing, there's an opportunity to really align the BHSA housing investments with APS referrals for older adults who are at risk of being unhoused, exploited, or have unsafe living conditions. You can pair housing with intensive behavioral health supports as well. So there's some flexibility and creativity around how you design that. And you can do that with housing providers, with community-based organizations that are specializing in that, particularly those that provide behavioral health services. Around short-term stabilization and recuperative care, funding can be used to support crisis residential or recuperative care options for older adults. This can also obviously prevent placement in inappropriate settings, right? So jails and hospitals. So you could design a intervention in collaboration with community-based organizations that is preventing folks from going to jails and hospitals to receive those services instead. And then financial exploitation, we know this is a big deal. And so there are opportunities to leverage Behavioral Health Service Act funds to support behavioral health clinicians working with APS workers on financial abuse cases and to assess capacity and support and protective interventions that can be in place for clients and their families. It can also provide, excuse me, therapeutic support during conservatorship or legal proceedings as well. So these are just some ideas to, help generate some thinking and brainstorming that you can do with community-based organizations in order to maximize BHSA funding for the work that you're doing. All right, I said a lot there. But I think it's just really so important to keep thinking about how we can work together as a system. We can do this in lots of different ways: workforce, sharing teams, collaboratively working on assessments and other, documents and processes to streamline those. And it's all about the client. It's about coming together to serve an individual who's impacted by all the social drivers that we're all committed to addressing. So thank you again for the work that you do. Thanks for giving me a few minutes to share some ideas. I hope it was helpful, and I'll turn it back to the moderators.
Awesome. Thank you so much, LeOndra, and Anna and Sarah. And I really hate to interrupt the flow because I'm like bursting with ideas for questions, really about the timing of the opportunity here, whether it be for the immediate planning process that's taking place in your counties, or in terms of building relationships for the next planning process, which, as you know, will kind of come around the corner in like a year and a half, right? That's what happens in a 3-year planning cycle. So, but I am going to give us a 5-minute comfort break, and hopefully you'll hang on to this energy from these presentations and thinking about the opportunities, and bring your questions when we reconnect at 10, help me with my math, 10:22. Feel free to go off camera and mute, and we'll see you back here shortly.